Hello and welcome everyone to the Pediatrics Crash Course series for the Pdcet 2024 aspirants, and this is lecture 1 of this series. We are starting the series from today only, and we will try to cover a few important topics as soon as possible. You have only 1 month, even less than 1 month left now for your exam, and you all know the pattern of the exam well, and only you have to study pediatrics and all the questions will be from pediatrics only. So just try to read as much as possible in the coming month. I know most of you are already working after your diplomas, so you don't have that much of time. So just I'm trying to cover a few important topics and important lines which can be asked in your exam. So you all have good base for pediatrics already, as you have cleared your DCH or CPS diploma exam. So it's not that you are very much new for pediatrics. So we'll try to cover a few important points, and in the coming lectures we will try to cover important one-liners which have been asked in previous year exams from pediatrics subject. So for more videos you can subscribe this channel. Handle is at Shishukare. Okay, so we will just begin. So first, the important one, Apgar score, you all know very well. You have applied practically also Apgar, but just keep in mind that in MCQ exams now from last 2 or 3 years you have no practice for giving any MCQ exam, and the diploma course is very much theoretical. The exams are theoretical or practical based clinical approach, so sometimes we make blunder in exams, so it should not happen. We should at least solve easy questions correctly. Okay, so Apgar, A stands for appearance, skin color, P for pulse, G for grimace, reflex irritability, A for activity or muscle tone, and R for respiration. So each of the parameter has been given 3 scores, 2, 1 and 0. So for appearance or skin color, if it's normal all over the body, then color 2. If extremities are blue or cyanosed, then 1. And if overall the body is cyanosed or pale, then 0. For pulse, more than 100 is normal, so score is 2. For less than 100, 1. And if pulse is absent, then score is 0. Grimace or reflex irritability, by putting the nasogastric tube in the nose, if the baby sneezes, coughs or vigorous cry, then score is 2. Grimaces, make some expressions, then 1. And if no response, then score is 0. Activity muscle tone, if the baby is actively moving all his or her limbs, then score is 2. If arms and legs are flexed, then 1. And if no activity is there, hypotonia is there, then its score given for activity parameter is 0. Now respiration, of baby is crying well and respiration is good, then score 2. If gasping or irregular respiration, then 1. And if no respiration, then score is 0. So the total score is 5 parameters are there and 2, so the total score is 10. Now a few points about Apgar score, routinely assessed at 1 and 5 minutes, and then every 5 minutes thereafter as long as the resuscitation is continuing. The 1 minute score gives an idea of what was going on during labor and delivery, and the 5 minute score gives an idea of response to therapy, that is how good resuscitation is going at that point of time. And just keep in mind, it's not predictive of outcome. So Apgar score is not predictive of outcome of that baby. However, infants with score 0 to 3 at more than 5 minutes compared to infants with score 7 to 10 have a worse neurological outcome, but it's not predictive. You have to keep this in mind. So birth injuries, important birth injuries like Erbs or Duchenne paralysis, Erbs paralysis, clump case paralysis. Erbs paralysis, C5, C6 nerve roots involved, and the baby cannot abduct shoulder. It's externally rotated and supinate to forearm. And clump case, C7, C8 or plus minus T1. It's sometimes involved, sometimes non-involved. And paralyzed hand and Horner syndrome can be present or not. So just remember C5, C6 in Erbs palsy, and clump case palsy C7, C8 and T1 can be there. So these are two important birth injuries. Now the other one is important topic, Caput succedaneum and cephalohematoma. The difference between both of them you all know very well. Caput is condition marked by localized soft tissue edema with poorly defined outline. Okay, and in cephalohematoma, condition marked by soft fluctuant localized swelling. So here the swelling is localized with well defined outline. So if the outline is well defined, it's cephalohematoma. If it's poorly defined, then it's Caput. Now Caput is caused by pressure of the fetal head against the cervix during labor, which decreases blood flow to the area and results in edema. So just simple physics, the pressure is there on the fetal head because of the cervix during labor, and that pressure leads to decreased blood flow and which causes edema, while cephalohematoma is caused by subperiosteal hemorrhage. So the pathology is different here, the mechanism is different. Caput is present at birth, does not increase in size, while cephalohematoma appears after birth and increase in size for the first 2-3 days. Now another important points can be asked as a one liner in MCQ. Swelling crosses suture line in caput, swelling does not cross suture line. Now this connects is localized, so swelling does not cross suture line. Caput disappears within a few hours or several days, and it disappears in several weeks to even months, so it takes longer time to disappear. Complications are very rare in caput, it's normal, while cephalohematoma complications include defective blood clotting, underlying skull fracture or intestinal bleeding, and jaundice can be seen. So important difference. So now also image based question can be asked. This is caput and this is cephalohematoma. Cephalohematoma is localized, caput is crossing the suture line, it's generalized. So go through this image based question can be asked. Now erythema toxicum neonatorum, it occurs in most healthy full-term newborns, usually on the second and third day. Multiple papules that rapidly evolve into pustules with an erythematous base. Lesion may become confluent, especially on the face. No fever, gone by 10th day. It can last even longer, up to 3 weeks also. And the differential diagnosis is malaria, herpes, bacterial folliculitis or scabies. Pustules smear revealing eosinophilic is diagnostic. So this can be asked, that pustule smear revealing eosinophils. So eosinophils are seen in smear made from pustules. What you will see, eosinophils. And biopsy shows folliculitis of eosinophils and neutrophils. So you all know all things, but the MCQ question which can be asked is pustule smear revealing eosinophils diagnosis of erythema toxicum neonatorum. Now IUGR babies, symmetrical and asymmetrical IUGR. Period of insult in symmetrical is earlier. Gestation, asymmetrical is later part of gestation. Incidence of total IUGR cases, symmetrical is just 20 to 30%, while most of the cases are asymmetrical. Each of the point can be asked for MCQ, so this table is important. Etiology, genetic disorders are more common because early gestation insult is there, or infection or intrinsic fetus, while in asymmetrical IUGR, which occurs in later gestation, so uteroplacental insufficiency is more common in later gestational period. Antenatal scan, head circumference, abdominal circumference, and biparietal diameter and femur length all are proportionally reduced in symmetrical, as the name itself suggests it's symmetrical, so all are proportionally reduced. While in asymmetrical, abdominal circumference decreased, biparietal diameter, head circumference, and femur length are normal. Cell number reduced in symmetrical, normal in asymmetrical. Cell size normal and reduced is not very important points. Ponderal index, now important one. So it's normal or more than 2 in symmetrical IUGR, while it is low or less than 2 in asymmetrical IUGR. So this criteria is used for diagnosis, asymmetrical, or differentiate between asymmetrical and symmetrical. So you remember this ponderal index point for both of them. The postnatal anthropometry, weight, length, and head circumference, reduction in all parameters, while in asymmetrical, reduction in weight, length, and head circumference are normal. So brain sparing growth is seen in, another important MCQ point, brain sparing growth is seen in asymmetrical IUGR. Now difference between head and chest circumference in term IUGR, less than 3 cm in symmetrical, more than 3 cm in asymmetrical. Now features of malnutrition, less pronounced in symmetrical while more pronounced in symmetrical, and prognosis is poor in symmetrical IUGR, it's good in asymmetrical because head circumference is normal and brain sparing growth is there, so asymmetrical IUGR has good prognosis. Okay, now coming to the infant classification and growth assessment, term and percentile. Now for LGA babies, large for gestational age above 90th percentile, and appropriate for gestational age AGA babies between 10th and 19th, but not between 3rd and 90th. Okay, sometimes we make mistake in solving MCQs. So small for gestational age SGA babies are below 10th percentile. Now infant of diabetic mother, important topic. Maternal hyperglycemia, either type 1 or type 2. Fetal hyperinsulinemia occurs. So insulin is a major fetal growth hormone, so increase in size of all organs except brain. Another important thing, all organ except brain. So major metabolic effect is at birth with sudden placental separation. What happens? Hypoglycemia occurs at birth. Infants may be large for gestational age and plethoric. And other metabolical findings which can be seen in infants of diabetic mother are hypoglycemia and hypomagnesemia. So calcium magnesium levels are to be sent and felt to be a result of delayed action of parathyroid hormone. So this can be asked in MCQ, that the metabolic findings like hypomagnesemia seen in infant of diabetic mother is due to delayed action of parathyroid hormone. Now common findings: birth trauma can be seen because macrosomia is there, large size baby, tachypnea, TTN, respiratory distress syndrome, cardiac failure, hypoglycemia, cardiomegaly, asymmetrical septal hypertrophy, important one. What type of cardiac defect is common? So asymmetrical septal hypertrophy is seen, insulin effect, and it's reversible. Polycythemia, hyperviscosity can be seen, which leads to polycythemia will lead to hyperbilirubinemia, so jaundice will be there. Renal vein thrombosis, flank mass, hematuria, thrombocytopenia, if seen present, then renal vein thrombosis can be suspected. Now increased incidence of congenital anomalies. What congenital anomalies? In cardiac, especially VSD, ASD in transposition, small left colon syndrome, transient delay in development of left side of colon, presents with abdominal distension, so small left colon syndrome is seen in IDM babies. Caudal regression syndrome, spectrum of structural neurological defects of the caudal region of spinal cord, which may result in neurological impairment. So caudal regression syndrome is seen in infant of diabetic mother. Now respiratory distress syndrome in newborn. Respiratory distress, grunting, more respiratory rate more than 60, retractions of sinuses. It can be either due to respiratory or non-respiratory. Respiratory again divided into pulmonary and extrapulmonary. In non-respiratory is the other entity. Now pulmonary, what all disease can be there? RDS, that is respiratory distress syndrome, transient tachypnea of newborn, neonatal pneumonia, meconium aspiration syndrome, pulmonary hemorrhage, pneumothorax, congenital lung disease. So these all are the pulmonary causes of respiratory distress in newborn. Extrapulmonary, upper airway problems, lower airway problems, mediastinal mass, ribcage abnormalities, or diaphragmatic pathologies. Now non-respiratory causes, cardiac causes, and congenital heart disease, neuromuscular, metabolic, or hematological causes can be there, and for the cause of respiratory distress in newborn. Now coming to RDS, it is respiratory distress syndrome. It occurs due to deficiency of mature surfactant, inability to maintain alveolar volume at the end of expiration. Okay. MCQ point can be there. So maintain alveolar volume at the end of expiration, decreased FRC, that is functional residual capacity, and atelectasis can be seen. Primary initial pulmonary hallmark is hypoxemia. Option can be there: hypoxemia, hypercapnia, what all. So hypoxemia is the primary initial pulmonary hallmark. Then hypercarbia and respiratory acidosis is seen. So first of all, this MCQ can be asked: the primary initial pulmonary hallmark in case of RDS is hypoxemia, hypercarbia, or respiratory acidosis. So go with hypoxemia. Now how to diagnose? Best initial diagnosis test is chest radiographs. Findings of chest radiographs: ground glass appearance, atelectasis, or air bronchograms. Most accurate diagnostic test is LH less than to sphingomyelin ratio, part of complete lung profile, less than to sphingomyelin ratio, done on amniotic fluid prior to birth. And the initial treatment is oxygen is given. Most effective treatment, oxygen CPAP is given. And the most effective treatment, intubation and exogenous surfactant administration. Surfactant administration is done. Now primary prevention: how to prevent? Avoid prematurity, tocolytics, or antenatal betamethasone is given to prevent respiratory distress syndrome of newborn. Now these are the lungs alveoli of newborn. Type 1 pneumocytes, type 2 pneumocytes. Type 2 pneumocytes proliferate in response to lung injury, act as stem cells, and surfactant contains phospholipids and decrease surface tension. So surfactant decreases surface tension, so alveoli remains expanded and it does not collapse. But in case of surfactant deficiency, surface tension increases and alveoli gets collapse. Now another disease is TTN, transient tachypnea of newborn. Slow absorption of fetal lung fluid. Why? Decreased pulmonary, it causes decreased pulmonary compliance and tidal volume with increased dead space. So what all pathophysiology is happening? Slow absorption of fetal lung fluid is there, so it is causing decreased pulmonary compliance, and it is tidal volume with increasing of the dead space. Tachypnea seen at birth. Minimal oxygen requirement is there, common in term infants, not in preterm. RDS was common in preterm. It's common in term infants delivered by cesarean section or rapid second stage of labor. So be aware, MCQ can be like this, that TTN is commonly seen in first option is cesarean section, and you just tick the answer, but second option can be there, that is rapid second stage of labor, and third option can be there, both of the above. So answer will be both of the above. Okay. So and chest X-ray, air trapping, fluid in fissures, perialar streaking, rapid improvement generally within hours to few days, mostly around after 72 days improvement happens. So TTN versus RDS. Transient tachypnea of newborn and respiratory distress syndrome. TTN, pathophysiology is delayed resorption and clearance of alveolar fluid, while here what is pathophysiology? Surfactant deficiency. TTN seen in term baby, RDS seen in premature baby. Signs and symptoms: mild respiratory symptoms, TTN, while respiratory distress and it worsens. In RDS, chest X-ray shows mild, some evidence of fluid or vascular markings, while in RDS, ground glass appearance or air bronchogamma and atelectasis is seen. Treatment: respiratory support until it improves. They are more severe and prolonged, so CPAP, intubation, mechanical ventilation, and surfactant is required in case of RDS. Now, next is congenital diaphragmatic hernia. Now you can see the intestinal or bowel loops inside the left lung side. So this is typical X-ray of classical diaphragmatic hernia. So failure of diaphragm to close, abdominal contents enter into chest, it causes pulmonary hypoplasia. So what happens in diaphragmatic hernia? Pulmonary hypoplasia. Born with respiratory distress and scaphoid abdomen, bowel sounds may be heard in chest. Diagnosis: prenatal ultrasound or postnatal X-ray reveals bowel in chest. Best initial treatment is immediate intubation and delivery. So bag and mask is contraindicated in case of diaphragmatic hernia. Diaphragmatic hernia, you don't give bag and mask if the baby is not crying after birth. You just intubate in the delivery room if the baby is known or suspected of CDH, followed by surgical correction when stable after a few days. Okay. Now, Omphalocele versus gastroschisis. Now, the features: Omphalocele cyto defect is central umbilical, while in gastroschisis it's right paraumbilical. Sac is always present. This is important, and it's never present. So sac is always present in Omphalocele. Now, Omphalocele, just to remember, Omphalocele O. So this is sac-like structure. So sac is present in Omphalocele. Anomalies of rotation and fixation is present in Omphalocele. It's also present in gastroschisis. Gender: more frequent in females. It's equal. Associated anomalies are frequent with Omphalocele, while it's rare with the other one. And intestinal atresia is rare in Omphalocele. It's seen up to 10% in gastroschisis. So important part is about sac, and sac you can remember that O is sac-like structure, so sac is always present in Omphalocele. Now, image-based question can be asked: Omphalocele and gastroschisis. So umbilical ring defect and abdominal content protrude into peritoneal sac. So peritoneal sac is seen in Omphalocele, while in gastroschisis abdominal content slip outside without any sac. So sac is not present. Okay. Now NEC, necrotizing enterocolitis, transmural intestinal necrosis is seen. Greatest risk factor is prematurity, and it's rare in term infants. Symptoms usually related to introduction of feeds. So once you introduce feed to the preterm babies and it develops these symptoms like bloody stools, apnea, lethargy, abdominal distension, and once perforation has occurred. So pneumatosis intestinalis on the, remember this one, pneumatosis intestinalis on plain abdominal film is pathognomic of NEC. So various X-ray findings can be given in the MCQ, and it can be asked which is pathognomic for NEC. So pneumatosis intestinalis. Treatment is cessation of feeds, gut decompression, systemic antibiotics, and supportive care. Surgical resection of necrotic bowel may be necessary. So this flow chart, let's go through this rapidly. Neonatal necrotizing enterocolitis in premature infants. So prematurity is a risk factor for them. What happens in premature? Decreased goblet cell in intestinal epithelium, immature tight junction in intestinal epithelium, decreased intestinal motility, increased toll-like receptor 4 expression on intestinal epithelial cells. Such question can be asked from pathophysiology, that involvement of which cell. So toll-like receptor 4 is increased expression of intestinal epithelial cell NEC, and aberrant bacterial colonization of the gut. So these are the 5 points. Now, decreased goblet cell intestinal epithelium, what it do? It does decrease intestinal mucus layer production, leads to impaired mechanical defense against pathological bacteria. So if the mucus layer is impaired, so the mechanical defense is also decreased. Now, immature tight junction in intestinal epithelium, what is the increased permeability of intestinal epithelial barrier? So both this leads to impaired gut barrier, allow for increased bacterial translocation. And toll-like receptor 4 on intestinal mesentery endothelial cells bind lipopolysaccharide and gram-negative gut bacteria. So this is all about pathophysiology. So just this now clinical. So important point is toll-like receptor 4. Okay, what goblet cell decrease, and then immature tight junction intestinal epithelium, so increased permeability. So all this thing. Now pneumoperitoneum is seen, abdominal distension is seen, peritonitis can be seen, intestinal perforation, short gut syndrome. Why? Damaged intestinal cells are unable to absorb nutrients, so short gut syndrome is seen. Bilious vomiting and bloody stools are seen in NEC in premature infants. Now Bell's staging, modified Bell's criteria: stage 1A suspected, 1B suspected, 2A definite mildly ill, 2B definite moderately ill, 3A advanced severely ill and bowel, and 3B is advanced severely ill or perforated bowel. So now go through this table, keeping in mind how MCQ can be framed. So MCQ can be framed in this manner that which of the following category of Bell's staging comes under definite NEC. So option will be 1A, 1B, 2A, all of the above. So answer will be 2A. So from second onwards, 2A onwards, it's definitive, and then 3 and 3B is advanced. So these are systemic signs. Now DIC is seen in which category? Which is stage 3rd A. DIC is seen. Okay. Abdominal signs, if we go through the abdominal signs, then any important abdominal sign. Radiographic sign. Now intestinal dilation, pneumatosis intestinalis. This is important one because this is pathognomic of NEC, so it is seen in 2A. So definite variety, it's seen pneumatosis intestinalis in radiographs. Okay. Pneumoperitoneum, if present, then 3rd B stage, and surgery is required in 3rd B, and on the previous stages also. Now it can be asked in a suspected 1A category, so and keep the baby NPO and give antibiotics for 3 days, antibiotics for 7 to 10 days in category 2, 14 days in category 2B, and NPO antibiotics 14 days, fluid resuscitation, inotropic support, ventilator therapy, paracentesis all should be done in 3A, and surgery is also required in these cases. Okay, now this is VACTERL association. V stands for vertebral anomalies, A for renal atresia, C for cardiovascular anomalies, T for tracheoesophageal fistula, E for esophageal atresia, R for renal or radial anomalies, and L for limb defects. So this was a short video today, few important topics, and we will try to present class at least every alternate day, or if possible daily. Okay, so thanks a lot for your patience. Go through these important topics in the next 5 to 10 minutes, and these are important for your exam. Thank you.